We are extremely fortunate to have one of the best hair transplant surgeons literally in the country to talk to us today about hair transplants in women. Is it a good option? And when is it a good option? So I want to thank you all for your patience and thank you all for joining us. I'm Dr. Mary Wendell. I'm the medical director of Medi Tresse, and our guest today is Dr. Mark DiStefano. Just introducing ourselves here. This is what we're going to talk about today. Dr. DiStefano has been doing hair transplant surgeries for over 20 years and has done more than 8,000 cases. So he's certainly one of the best experts in the country on this topic. We've been doing hair transplants in women for a while now, and the newer treatments have made it a little bit different in terms of who gets considered a good candidate for hair transplants or not, but Dr. DiStefano will talk to us about that. Just a quick update for those of you who have joined us before. We are finally, thank goodness, in Massachusetts open. We are doing in-person visits for treatments only at this point. We're still doing our video consults and follow-ups, at least through the end of the month. We will decide in July as to whether or not we'll fully open for all patients, but we'll continue to do treatments. In Scarsdale, we're in the process of reopening our office according to the rules and regulations in the state of New York. We are slowly getting back to normal, as are all of us in terms of our lives. As usual, our staff is always always available for phone consults or video appointments. We highly recommend still doing video appointments at this point, other than treatments. We will work very hard to get everybody back into the office in the near future, even those individuals who've had a video consultation. We will get you back into the office when we feel it's appropriate. We continue to ship products as needed. That is still ongoing. Just a quick update in terms of female hair loss. The vast majority of female hair loss is androgenic, although I'll talk about a little bit other options as well. The three phases of growth in the hair are the anagen cycle, which is the normal growth cycle. This is the longest part of this cycle. This is when the hair follicle gets all of its nourishment through the blood supply. Once the anagen phase is over, the hair follicle slides into the catagen phase, which is really the transition phase where growth stops. And then the telogen phase is where the hair actually pulls away from the follicle and then falls out. There is a period of time after the hair falls out before a new hair is then starts to regrow again. In androgenic alopecia especially, the entire cycle of the hair cycle does shorten, which means that the hairs turn over at a faster rate, which also can contribute to slightly increased shedding in women who do have androgenic alopecia. We've listed here the most common causes of hair loss in women. As I mentioned, the #1 cause is androgenic alopecia or female pattern hair loss. We also have telogen effluvium, which is very common and fortunately tends to be reversible once the cause of the shedding is discovered. Traction alopecia is when the hair follicle gets damaged due to excessive pulling, usually due to specific hairstyles, like very tight braids or dreadlocks. This is not an uncommon side effect. Alopecia areata is an immunologic disease where the hair actually falls out due to acute immune reaction in the hair follicle. And post-cancer hair loss is something we're seeing more and more of, which is actually, when you think about it, a good thing because more people are being cured of their cancer. It's not uncommon, though, to have some permanent hair loss as a result of treatment. And we're seeing more and more women come in. Scarring alopecias are less common, but unfortunately the incidence is increasing and we don't know why. In scarring alopecia, there's actually destruction of the hair follicles, so treatment is really to prevent further loss. And hair transplantation can be utilized once the scarring is under control. The three most common types are frontal fibrosing alopecia, or FFA, CCCA, and LLP, which are also unfortunately increasing in frequency. When we see a patient in the office, the first thing we do is we try to diagnose the cause. Without knowing the cause, we don't know what the proper treatment is. We take a complete medical history as well as a hair loss history. We do a thorough examination not only of the hair and the root, but also the scalp, because there are many scalp problems which can cause hair loss. We go through the entire medical history with our patients, because oftentimes the medical history can play a role and give us a clue as to what the cause of the loss is. We do trichoscopy, which is what's shown on this photo, which is a magnification of the scalp and the hair follicle. And we also oftentimes will do blood work to help us make sure that there's no other contributing factors like anemia, vitamin D deficiency, hormonal imbalances, which can play a role in hair loss. Rarely we will do a biopsy. Really, it's only if we're not sure what's going on, which is unusual once the thorough evaluation is taking place. The treatment plan can vary significantly depending on what type of hair loss the patient has and how far the hair loss has progressed. And with that in mind, I'm going to transfer this over to Dr. DiStefano, who will talk to you about hair transplantation in women. Thank you.
Hello, everyone. I'm glad that I'm able to be on this webinar with you. I hope that you'll find it helpful in what your treatment plan will be. Certainly what Medi Tresse tries to do is the best in terms of treatment. Medi Tresse was founded because of the medical treatments that we can do for women now, and I'll get into that in a little bit more. Next. We'll talk about these things. And what is a hair follicle? A hair follicle is comprised of a bunch of different cells. They produce hair. Hair is not alive. It is a keratin product, which is similar to your fingernails, and it is something which grows in a cycle. The hair does not cycle all at the same time, because if it did, every few years would all be bald and then it would grow again. You can just see the different composition of the hair system. Basically, you've got the follicle on the bottom. The yellow is. Let me see if I can do that better. Hold on one second. Michael, can you mute me, please?
While he's doing that, I want to just let people know that there's a Q&A section on the your questions, which we will then address at the end of the seminar. There are some questions in the chat which I will look at, but we would prefer the question and answers be in the Q&A section, which we will address at the end. Thank you.
Okay, can you hear me better now? All right, so thank you for the information, Doris, appreciate it. So in terms of the hair follicle itself, the growth cycles, we'll go over that next. Next slide, please. So the growth cycle is one of anagen, which is the growth phase, telogen, catagen, excuse me, which is the middle phase, and getting ready for the hair to shed, and then you've got the telogen when the hair sheds. The important part of this is that in a healthy hair, the follicle itself will disengage from the hair. It'll move up, and during the cycle, it will then again move back down and start producing. As the hair itself gets unhealthy, the follicles themselves, they actually will move up again and they will not be active. They're still present in the scalp, and we're certainly trying to figure out a way to reactivate those, but presently it's not possible. So when we think of male hair loss, we think about male pattern hair loss. 95% of the men with hair loss have this type. It's different than the women. As you can see in the diagram there, you see that the men tend to lose at the temporal areas and then maintain a bridge behind it, and then they start losing in the crown itself. And eventually the anterior loss and the crown loss converge, and you'll end up with significant loss. As opposed to the women who have female pattern hair loss, you see a thinning diffusely. One of the telltale signs is a widening of the part. And when you see that, the classifications are, it's called Ludwig classifications. You're able to see that. Now, women can have male pattern hair loss as well. The difference between the two is in the male pattern, you have a very stable, at some point, occipital or back of the scalp hair. And this is the hair, this is called the safety zone. This is the hair that we use to transplant to the front of the scalp. With the women, their hair diffusely is lost. And as a result of that, the donor area may not be as stable, and the transplant, not that it won't work, but it won't be quite as efficient as doing a male pattern restoration. But because of that, with the diffuse loss in the women, medical therapy is very effective, whether it's the PRP, vitamins, laser caps, and there's a variety of things that are coming out. The women will do much better with the medical treatment. So generally the hairline remains intact, and it is certainly very unusual for a woman to go completely bald. Next slide. This is Dr. Norman Orentrack. He is considered the father of modern hair transplants. He did the first hair transplant. The way he discovered it was he was doing some biopsies, moving from one place on the patient to another place, and he noticed that when he was doing those in his experiments, that hair was growing here on the arm or wherever he took it from. And so he decided to try movement of scalp hair, and obviously was successful. And this is what became eventually known as the plugs or the doll hair. That was in the early part. But prior to him, and there were Japanese doctors who actually discovered the first hair transplants. Unfortunately, all of their work was lost because World War II came in at that point. And those were just recently, their works were just recently discovered around the, I hate to say the turn of the century, but the turn of the century. And once the plug started, it was determined that they were just too thick, obviously. And these were then quartered and placed in. Then they found out that one of the doctors, Dr. Bobby Limmer, found out that if you took the hair itself in a strip and you cut it off into what we call follicular units, which is what comes out of the scalp, whether it's one follicle, two, or three, you can cut those up into the small follicular units, and then you can reimplant those, and they are not pluggy. And that was the start of the modern hair transplant. We are now doing another form. The first one was the FUT, follicular unit transplant, and there's now an FUE, a follicular excision, a follicular unit excision. And with this, you take them out one at a time. Generally, the strip is better for the women because you don't have to shave a large area. With the FUE, you have to shave a very large area to get the number of grafts you would need. So with the strip, you end up with a very fine scar, and with the FUE, basically you have little scars, but most of the time they're not noticeable. Obviously, women are not going to shave their head, and so neither of those scars will show. Next slide. The hair follicles are removed from the donor area, or the permanent section is what we call it, and they're placed in the recipient area. They have donor dominance, and what that means is that when you move the hair from the donor area and you place it in the recipient area, it acts like it did in the donor area. And if it didn't do that, then you would lose the hair. So the question is, why does the hair from the back stay and the hair from the front not remain? And they basically develop from two different tissue types in the forming embryo. Next. The follicular unit transplant, you can see on the right-hand side, take a strip of hair. It can be anywhere from 1/4 of an inch to half to more likely half an inch. And the strip can be anywhere from 2 inches all the way up to 5 or 6 inches. Once I remove the strip and close the area, I hand the strip off to my technicians, and they actually transform it into individual follicular units. Those are then placed aside, and the hairline or whatever area we're working on is anesthetized, and all the holes are made by me in the proper angle, direction, and depth of the scalp. The technicians then will take the grafts and they'll place them for me. The cutting and the placing are very tedious and take a long time. We have anywhere from 2 to 3 technicians working on that at any given time. And that's why the technicians do that portion of the work. Next. Next slide, please. Okay, the follicular unit extraction, we actually take a punch. For me, it's a motorized punch. It started off from Jim Harris out in Denver, Colorado, who started using a manual punch where he would actually, with his fingers, and then he'd use the sharp first, and he'd use the dull afterwards to go through the follicle, the depth of the follicle. And the reason for that is try to minimize the transection of the follicles themselves. And so now we have motorized punches. We actually have robotic machines that will make the incision, but they still have to be removed manually. And the problem with the robotic, in my opinion, I've used them, but they're only about 80% effective. So for every 100 grafts you take out, you only get about 80. When I do that manually, I get between 92 and 95%. And again, the reason that women do not generally do this is because the donor area must be shaved. And if you're getting 1,000, 1,200 grafts, you're going to shave an area that is anywhere from 8 inches long to 2 inches wide. And it's very hard to cover, obviously, and it will take a significant amount of time to grow. So most women opt for the follicular unit transplant. Next slide. Are women good candidates? Well, they are in certain instances. Once again, it's the medical treatment for women has dramatically changed how we do, how and when we do transplants for women. When I first started my practice, and probably for the first 10 or 15 years, I've been doing it for over 25 years now, I had approximately 20% of my practice was women. Today, my practice runs anywhere from 3 to 5%, and it's much more specific than what I was doing back then. The men were definitely more satisfied with their results than women were, because we would do them for diffuse loss, and it was hard to get enough density to make a significant difference for them. The ones who were much more likely to be happy were those who needed a new hairline because their hairline was gone, those who had bitemporal loss, or if they had traumatic loss. Sometimes we would do it on the scarring alopecias after they had burned out, and it was at least a year to a year and a half. The only problem with that is that the hair did not grow very well in the scar area, but it did grow. The loss in the particular areas, as I said, were the hairline, the trauma loss, temporal recession, and even in the part. One of the things we'll do is when you look down from the top and widen part, if the part is going to be with it, keeping it all the time, then we can take about a 1-inch wide strip and plant in there all the way down from the frontal hairline all the way back to the crown. And women seem to be very happy with this. Next slide. So this is the Ludwig classification for women's hair loss. And you see, the basis of this is basically seeing the transition from the part being normal all the way to the part being wide. And you can see that it may develop into the severe crown area the severe top of the scalp, front and back. But usually that just is not the case for women. Next slide. So here are some before and after photos. The woman on top and on the left, she wanted a lower hairline. These slides are thanks to a doctor from California who I trained, Dr. Shah Benham. And you can see that there were 1,800 grafts approximately. And in the average Caucasian, the number of hairs in each graft is about 2.2. So most of the hairs are going to be 2 follicles, then 1, and then 3 follicles. And it can go anywhere up to 4 and even 5. It tends to be with the Scandinavians who have very thin hair, they have more follicles per follicular unit, and the African Americans who have very thick hair have less follicles per unit. And it seems that it kind of evens out in terms of the look of density. So you can see that the result from this was dramatic. Next slide. Again, this is the same thing. Next slide, please. So here's a woman who wants to move her hairline down, and you can see the temporal recession on the side. This is on the right-hand side, you see what it looks like immediately after surgery. We have to make a female hairline, obviously. Having temporal recession, it's significant temporal recession is not a normal female pattern. So what I will frequently do is when the patient comes in, I will ask them to draw the hairline that they want, and we'll check it out. If I'm okay with the hairline, we'll move forward with the procedure. If I have some concerns, I will explain what they are. And if the patient doesn't want to change what they want, we will move forward. If they are receptive to what my suggestions are, then we will adjust it and move forward from there. Next slide, please. We do eyebrow transplants as well. This is an earlier one of mine. And what you see is, I did a right and a left on this. This is probably 75 to 100 grafts. In my eyebrows now, I'm doing between 200 to 300 grafts. They're much closer together. They look a lot better in the end. And unfortunately, I don't have any after pictures of these. Next slide, please. Okay, one last thing about the eyebrow. We also do eyelid transplants. The thing about the eyebrow and the eyelid transplants are that they have to be trimmed, because just like I said, donor dominance, they will continue to grow. So you're not going to want to have them grow out too far. There is a difference in shape between your natural hair and what a normal eyebrow hair looks like. A normal eyebrow hair looks like a cone, a very thin cone at the end. It's sort of, if you look at the picture of the woman on the right-hand side in this, that's how it actually goes down. It's a little bit wider at the top and definitely narrow at the bottom. So that's a slight difference. It doesn't affect it overall. And sometimes we combine the eyebrow transplant with I forgot, micro, I'm blocking on it, that we do tattooing of the eyebrow itself. So it's been very successful. Women in several of the women in our office have used it, and I'm very happy with it. Thank you so much for listening. Are there any questions?
Yeah, okay, I'm unmuted. I just want to make sure people could hear me. There is a question a woman asked, and there's multiple parts to this question. And the first part is, what is the cost? And the cost is extremely variable and is totally, and you know, Dr. DiStefano would attest to this. It's totally dependent on how much surgery is needed, how many grafts are required. It's really based on the numbers of grafts. And I wouldn't even want to give you an amount because it's so variable and it's so dependent on how much hair needs to be transplanted. The other part of the question is, are those on hormone replacement therapy and or thyroid medication still good candidates? The answer is absolutely yes. Hormone replacement therapy should never be a contraindication to having hair transplant, as long as your hormones are in good level, which is to recommend people get tested before they have any kind of hair loss treatment, making sure their hormone levels are at a good level. Particularly if a woman's taking testosterone, which when someone's having hair loss, we don't recommend testosterone, but estrogen and progesterone actually can be helpful for hair growth. But again, the levels need to be tested and appropriate. Same is true of thyroid medication. Thyroid, as long as the thyroid levels are therapeutic and not too high or too low, should never interfere with having a hair transplant or any kind of hair loss treatment. This particular individual said she was not responsive to PRP, and the question is, how might this affect the success of a transplant? And really, I wouldn't anticipate that is an issue. It's a different type of procedure. You're actually taking hair that's healthy and still growing and putting it in a place where there is less hair, and PRP is a totally different type of treatment than hair transplant. Oftentimes PRP can actually help hair transplants, but it's not necessary by any means. And so we oftentimes, if a woman comes in and has fairly aggressive hair loss, we oftentimes will try PRP first because women tend to have more of a diffuse hair loss, which is not as amenable to hair transplants. So we oftentimes will do PRP treatments first and see if they can get an adequate response with the PRP. If not, then it would not be unusual for us to say, well, have you considered a hair transplant if we felt that they were a candidate? Not responding to PRP does not exclude the possibility of being successful with a hair transplant. I hope that answers your question. And in terms of cost, I hope you don't think I'm being evasive, but it really is extremely variable and totally dependent on how much hair needs to be transplanted.
Mary, can I talk for a minute?
Go ahead. I can't, you're a little hard to hear, so.
Okay, can you hear me better now?
That's better.
Okay, so in terms of the cost, let me address that a little bit. First of all, on our website for the hair transplants, we have what we call honesty in pricing or whatever. And our pricing runs, first of all, if you're going to do the excuse me, if you're going to do the FUT, it runs $5 a graft for the first one, and I believe $2 a graft. I'm sorry, $5 a graft for the first 1,000 and $2 a graft for anyone after that. So with that in mind, depending on how much hair loss, and I'll just give you a rough idea. This does not pertain to any one person, obviously, but if you're going to do the frontal hairline, you're looking at probably around $4,000 to $5,000 realistically. If you're going to do the temporal areas, depending on the depth of it, it could be anywhere from 700 to 1,000 grafts. So once again, you're looking at anywhere from approximately $4,000 to $5,000. If you're going to do eyebrows, that's a little more expensive. And one of the questions is, where do you take the hair from? Basically, we take it not necessarily from the very back of the head. We're going to take it from an area that we feel is a little bit more soft looking, so that we can have a little bit softer look in the eyebrow itself. But if you look at some of the women in the women's magazines, you'll see that prominent eyebrows are really in, and so a thicker hair may be used for that. But once again, the women who are experiencing hair loss generally don't have thick hair. They have thinner hair than most anyone who doesn't have hair loss. I hope that answers the questions on all of those. If there's any other questions, I'd be happy to address those as well.
Thank you. One woman asked, she's on an aromatase inhibitor, which is not uncommon post breast cancer. Should she wait until she finishes it before doing a transplant? That's a really very, very good question. We do know that these medications can cause hair to thin. And I think the timing would really depend on how much more time left you're going to be on the medication. The recommendations for treatment, unfortunately, change. If it's only a few more years to be on the medication, you might want to wait a couple more years. If it's longer than that, it's a discussion that would need to be done and careful consideration. It doesn't mean that the transplant wouldn't work. If the transplant would work, the transplant would still, the hairs would still grow. The problem is that these medications do tend to affect the hairs that you already have and make them thin a little bit faster. It would not affect the success of the hair transplant, but if you're going to be on them long term, even the transplanted hair may be affected over the long term, not quickly, but over the long term. So again, it's an excellent question, and it's a discussion that would need to be made between you and the hair transplant surgeon, and determine the best time to do it. Again, wouldn't exclude it, but it's something that would need to be considered.
If I may address a couple of these questions.
You want to take the next question?
Yes. So we're talking about the can the transplantation help with general diffuse thinning versus the hairline recession shown? Once again, I think Dr. Wendell addressed it a little bit, but yes, it can. If you're talking about a particular area, and that's why working in the part works well. To try to do the whole head in general is not usually going to do well, because there's existing hair, and to try to get it even closer together sometimes can be difficult. So I would say you want to look at the part or any other areas that are specific problem areas. And then Nancy asked how much additional hair loss would be expected during the process of placing donor hair in the middle of the part area. What I tell my patients is that between 20 and 25% may be cut accidentally. I think of it as like a mini haircut. I'm making a lot of very small, my punch, or not punch, I'm sorry, I don't make holes in the front of the head. What I make, and I don't take tissue out, what I do is I just make a slit, and the graft is placed in the slit. But sometimes a hair is overlapping in the way, whatever, and I may cut that hair. So I try to give a high number between 20 and 25. In most cases, it's maybe 15%. But again, it depends on the amount of hair that's there. Are there any potential risks? Well, the answer to your question is there's risks to everything. In all of my years of doing this, I've never had a serious issue in terms of life-threatening risk or anything like that. The most common thing is what we call folliculitis. It's an inflammation infection in the hair follicle itself. And we do see that occasionally, and it's treated with a simple antibiotic, and it goes away. So in terms of rejections of grafts, no. This is in vitro, we call it. And so we're taking your hair, moving it to a new place on your scalp. It's no different than giving yourself blood. You don't have to type and cross or any of that stuff. You can just take it out and give it back again. Two doctors in England at one point did a hair transplant on each other, and they used each other's hair, and it was awful. They got a lot of scarring, almost total rejection. So it's not something you'd want to do. Let's see the next question. Are there any more? I'm not sure what the 3 more years means.
No, I think that was an answer to a previous issue.
Oh, okay.
Can you
the question, someone asked me, do I do robotic hair transplants? I don't own a robot myself. I do have access to robots for hair transplants. They are more expensive, and you get less hair out of it. It's not something that I like doing, but if someone were to, if that was their preference, I would certainly be willing to do that. But once again, the value just, to me, is not there for the patient. Not only do you not get as many grafts per punch, but you also will have to pay more, approximately $1.50 more per graft. So I just don't think it's worth it. So I wouldn't recommend it.
Can you go into more detail in terms of what the post-operative process is, the day after, the weeks after? What is the healing process? How long can you expect to wait before the hair starts to come in?
Okay, so the process, you're going to be in the office for anywhere from 4 to 6 hours. It's all done under local anesthesia. We do give Valium if necessary. If we give Valium, you can't drive yourself. 95% of my patients will drive themselves. When you're done with the surgery, you're probably a little tired. We definitely feed you. We want to give you some snacks as well, so you get snacks, lunch, and any drinks you want. You can get up if you need to stretch or go to the bathroom, whatever. We send you home most of the time without any sort of wrap on. We send you home with a baseball cap. We tell you to sleep in a slightly elevated position. You will go home with prednisone, which will help to stop any swelling, a Keflex or some similar antibiotic to try to prevent infection, and then some pain medication. The pain medication, you get enough for a day or two. You're going to be on the prednisone and the antibiotics for 5 days. The first day post-op, we're going to have you take it easy. You are going to wash your hair that day. Later in the afternoon, you'll get all kind of instructions. You get a very detailed post-op instruction list. And by the second day, you'll be able to do light workouts. When I say light workouts, you can go for a walk, you can play golf, no swimming, anything like that. No heavy lifting. So you can have your husband do all the housework if he's not doing it. And let's see, what else can you do? On the 4th day, you're going to be washing your hair normally again. And the reason for that is that we want to get any scabbing off there. If you follow instructions, which most of the patients do, you'll have all the scabs off on your head within 7 days. There may be some residual redness, and within 10 days, no one's going to know you had the procedure done. After 7 days, you can do full workouts, whatever it is you do, whether it's yoga, boot camp, lifting, bicycling, whatever. In terms of swimming, until all the scabs are off and it's healed, we don't want you to go in lakes or pools. You can go swimming in the ocean after 3 or 4 days. The salt actually helps it. By the end of the 3rd day, you don't need to sleep in a slightly elevated position. You can sleep in however you normally sleep. You can lay on the grafts at that point. They will not come out. I have never had a patient lose a graft that wasn't traumatic. In other words, getting into a car, bumping their head or whatever. And there's only been a few of that over the years with all the surgeries I've done. So it's really not a real worry or concern. If you have the strip surgery, you're going to come in at
12 to 14 days to have any sutures or staples removed that are going to be back there. Obviously that'll be a post-op check day for you. If you don't have to have that, if you're not having any removed because you had the FUE, you're going to come in at a month for a month checkup. Depending on how much hair is in place in the area that we worked on, you can see growth anywhere from 3 to 6 months. So what you will normally see is at 6 months, 40 to 60%, at 9 to 12 months, 60 to 80%, and it can take up to 1.5 years to 2 years to see the final result. But realistically, by 18 months, you'll see most of what you see. So what is the recovery like? I'll be honest with you, women tolerate the whole thing much better than men do. And generally after a couple of days, you're back to feeling how you normally would feel. With the FUT, you are going to feel some pulling in the back, and that'll go away once the staples are removed. That's just very typical. So that's probably the biggest discomfort. It's not painful. It's just you can notice it's there. So does the hair removed from the transplant area ever grow back? Think of it like a tulip bulb. If you have a tulip bulb in your garden on the left and you move the tulip bulb to your garden on the right, the whole thing is gone. So it's not going to grow in from where you took it from. Well, this is the same thing. Having said that, though, when we remove the strip, we bring hair to hair bearing areas back together. You would never notice that the hair is gone. It is virtually, I've never known anybody to tell me that, they could notice. When we do the individual graft, what we do is we end up not taking out every single one. We take out 1 in 5, 1 in 4, 1 in 6, so that you have surrounding hair, and you would never notice that once again the hair is gone. In terms of, do we do hair transplants in Wellesley? We don't at this time. Just before COVID, we were actually taking a lease out on a bigger space, and unfortunately, with the COVID, we decided not to at that moment. We're going to wait till things come back to normal, and my expectation is within the next 6 to 9 months, I hope to be able to start doing transplants in Wellesley. But right now, we only do them in Worcester, which really isn't that far from Wellesley. So,
can you comment on the possibility of shock loss after surgery?
Sure. Shock loss is less of an issue for men because they generally don't have much hair where I'm putting the hair, but more of a significant issue for women. And the reason for that is that, again, with diffuse loss, you still have hair in the existing area. It's usually pretty spaced out evenly over the top of your head. So when I do a procedure and you get some shock loss, you can lose anywhere from 20 to 30% of the existing hair to the shock loss. That will grow back, and it will grow back in pretty much the same time as the new hair is growing. So the answer to your question is yes, you do get shock loss. You can use makeup or cover up on there. There's several different things on the market that we could show you so that you would be able to help cover up that area, and it wouldn't be anywhere near as noticeable as if you didn't use it.
I think it's important to realize, though, that it doesn't happen to everybody, and it doesn't happen to the same extent. So unfortunately, we can't anticipate who that's going to happen to. But the good news is there's generally complete recovery of the shock loss while the hair transplants are growing in as well.
Yeah, and we're giving the prednisone to help stop the shock loss as well as any swelling that may happen. So.
Okay, well, I think that's the end of our questions. We appreciate the time that you've taken to listen to our presentation and ask questions. Certainly, if you have further questions, you can reach us through our website, and you can leave any questions you have there, and either I or Dr. DiStefano can get back to you if you have this very specific question in regards to hair transplantation. it's a treatment for hair loss that has really evolved to being much more specific for very specific individuals, but for those people, it can be a very good choice for them. So even though we're not doing as many hair transplants on women, we're selecting them very carefully. And for those women that we make the decision to move forward on hair transplantation, it oftentimes is a very good choice for them. Keep in mind, particularly in women who have androgenic alopecia, we want them to continue with other treatments so that they can continue to sustain and maintain the hairs that they have. It doesn't mean that once you have a hair transplant, you have to stop everything else. We actually encourage you to continue with the other treatments. For someone who has traction alopecia, where the hair is missing out of the front due to pulling and twisting, generally hair transplantation works very well. It fills in those areas nicely, and the treatment is not necessary in that particular case. Scarring alopecia is, again, a little tougher because in the areas where the hair loss has taken place, there actually is loss of the existing hair follicles. They put new ones in and those will grow. But timing is very important to make sure that the rest of the inflammation and the rest of the scalp is under good control. So each patient is carefully chosen and managed carefully before making the decision to move forward with hair transplantation. But for the individuals that we do recommend it for, it can be a very good choice for them. So we thank you for your time. Any questions, please go ahead and leave us any questions on our email on our website. And we appreciate you taking the time to spend with us today. Thank you.